We live in this era of just absolute instant gratification.
Totally. Like, we want everything yesterday.
Right. You want a package, it arrives the next day. You want, say, plumper lips or smoother cheeks. You go get a traditional hyaluronic acid filler, and boom, there's instant volume before you even step away from the mirror.
Yeah, you see the result literally immediately.
Exactly. We are so heavily conditioned to expect our aesthetic and medical solutions to just be immediate. But today, for this deep dive, we are looking at a treatment where you have to, like, completely abandon that instant fix mindset.
You really do. It requires a lot of patience.
It does. We are exploring intimate polynucleotides. And yeah, if you've seen the recent headlines, we were talking about highly purified DNA fragments.
Specifically extracted from the sperm of salmon and trout, which always gets a reaction.
I mean, it sounds completely wild, right? But these are actively being used to deeply rejuvenate vaginal and vulvar tissue.
It really does sound like science fiction when you first hear about it. Or like some weird internet rumor.
No.
But the clinical reality of this treatment is profoundly reshaping how we approach regenerative medicine, especially in women's intimate health. Because we're moving entirely away from the concept of simply filling a space.
Like traditional fillers do.
Exactly. And we're moving into the territory of actual biological reprogramming.
Which means the timeline for success looks completely different. So, for you listening, our mission today is to dig into a very comprehensive stack of sources.
And we've got some great data today.
We really do. We're looking at clinical research papers, specifically this highly detailed 2019 prospective cohort study by Palmieri and Raichi.
That's a landmark study in this space.
Yeah, and we're looking at it alongside actual treatment protocols from leading clinics like the Women's Health Clinic, Serenity Women's Clinic, and MySkin.
Real-world applications.
Exactly. And we're taking all of this data to answer one very specific, highly searched question. How many sessions of intimate polynucleotides do you actually need?
Because it's definitely not a one-and-done situation.
Right. Because if this isn't an instant fix, you need to know the exact timeline, the biological mechanisms demanding that timeline, and, what the clinical data actually proves about the results.
And understanding that specific number of sessions isn't just a matter of scheduling your appointments. It's really the ultimate key to understanding how regenerative medicine operates at a cellular level.
It's setting expectations.
Yeah, because if we are trusting the body's natural cellular cycle to do the heavy lifting, we have to play by its temporal rules.
So let's start with those rules, because I was looking through the biochemical mechanisms in our sources, and it's fascinating.
It's incredible biology.
It is, because traditional dermal fillers, mostly cross-linked hyaluronic acid, they essentially just sit under the skin.
Right, they just take up physical space to add immediate volume.
But polynucleotides, or PNs, are bioactive molecules. They aren't just physical bulk, they are actual chemical messengers.
That is the critical distinction here. Polynucleotides are polymers of deoxyribonucleotides. And when they're injected into the mucosal or vulvar tissue, they don't just sit there like a gel.
So what are they actually doing?
Well, they actively bind to specific receptors on your cells, most notably the A2A adenosine receptors.
Okay, A2A receptors.
Right. And when a polynucleotide binds to an A2A receptor on a fibroblast, it triggers this massive biological cascade. It basically shifts that cell from a sluggish, senescent state.
They're like a sleepy cell.
Exactly, a sleepy, aging cell. It shifts it into a state of active proliferation, so it upregulates the production of type I and type 3 collagen, elastin, and it even stimulates angiogenesis.
Which is the creation of new microscopic blood vessels, right?
You got it. It's literally bringing new blood flow to the area.
Okay, so instead of using the classic analogy of traditional fillers being like stuffing a pillow, let's think about it in terms of like structural engineering.
I like where this is going.
So using a traditional hyaluronic acid filler is like bringing in sandbags to stop a flood. The sandbags take up space, they block the water, and they give you an immediate visible fix.
Right, but the underlying problem is still there.
Exactly. The structural integrity of the dam itself is still totally compromised. Injecting polynucleotides, though, is like handing the local cells the architectural blueprints and a massive shipment of raw material.
Oh, that's a great way to put it.
And it's telling them to actually rebuild the concrete dam from within.
I love that analogy because it really highlights the fundamental constraint of the treatment. You can hand over the blueprints, you can deliver the materials, but the local cells still have to do the physical work of mixing the concrete and pouring it.
And that takes time.
That metabolic process takes real time. You are quite literally growing new, healthy tissue architecture to heal real disruptive conditions, things like vaginal dryness, dyspareunia.
Which is painful sex, for those who might not know the medical term.
Yes, exactly. Or the severe tissue laxity that follows childbirth or menopause. It's essentially a biological construction site.
Which brings us perfectly to the consensus on the actual timeline. Looking across the clinical guides we reviewed, whether you are looking at the protocols for specific PN products like Nugen, or reading the guidelines from these specialized women's health clinics, a very rigid schedule emerges.
It's remarkably consistent across the board.
It really is. The baseline protocol for intimate areas is typically 3 to 5 sessions, and those sessions are spaced specifically 2 to 3 weeks apart.
Yeah, that 3 to 5 session window is really the clinical sweet spot.
Why is it different from the face, though? Because facial protocols are sometimes shorter.
Well, the intimate tissues, specifically the labia majora and the vaginal mucosa, have vastly different demands than the skin on your face. When we're treating deep functional issues like restoring the extracellular matrix in tissue that has been completely starved of estrogen, a single session of signaling simply isn't enough.
It's just not enough to achieve lasting structural change.
Right, not at all.
But logically, this raises a major logistical question. If I'm an impatient patient, say, I have a romantic anniversary trip coming up next week.
Okay, I see where this is going.
Why can't I just blast the tissue with 3 sessions spaced, like 3 days apart? Why the strict 2 to 3 week biological window?
Because you would essentially be throwing away the product and your money.
Really? It just wouldn't work.
It comes down to receptor saturation and the mitotic cycle of the fibroblasts. When you inject the tissue, those A2A receptors we talked about become totally saturated with the polynucleotide signaling molecules.
So they're full.
Exactly. The cells get the message, and they start the complex multi-phase process of collagen synthesis. If you inject more PNs just 3 days later, those receptors are already occupied. The cells are already working at absolute maximum capacity.
They can't work any faster no matter how much you yell at them.
Right. In pharmacology, we actually call this tachyphylaxis. It's a rapid decrease in response to a drug after repeated doses over a short time. You literally cannot speed up cellular biology by just flooding it.
That makes total sense.
The tissue requires that 2 to 3 week window to process the signal, build the initial proteins, and then reset the receptors to actually receive the next signal.
Okay, so what happens on the other end of the spectrum? Say I do my first session, but, work gets incredibly busy, and I wait 2 or 3 months to go back for session number 2.
Then you lose all of the compounding cellular momentum.
You just lose it.
Pretty much. The whole point of the 3 to 5 sessions is to stack the biological response. You wake the fibroblasts up, they start producing collagen, and just as that cellular activity might naturally begin to plateau or downregulate, boom, you hit the receptors again at the 2 or 3 week mark.
So you're keeping them working.
Exactly. You force the cells to maintain a sustained peak of neocollagenesis. If you wait 3 months between sessions, that initial burst of activity is completely faded out.
Ah, so you're basically starting from scratch.
You really are. You're losing the compounding structural interest of the treatment, if you want to think of it like a bank account.
And that structural momentum is exactly what Palmieri and Raichi tried to quantify in their 2019 prospective cohort study. Because it's one thing for a medical clinic to just put a 3 to 5 session protocol on their website.
Right. Anyone can write a protocol.
Yeah, but it's another thing entirely to look at the hard clinical data proving why this specific sequence is absolutely necessary.
And that 2019 study is really a landmark piece of literature for this field. Because it didn't just look at aesthetic improvements, making things look a little plumper. It looked at profound medical intervention.
Right. They specifically followed 19 postmenopausal women, ages 50 to 65. And all of these women were suffering from confirmed vulvovaginal atrophy.
Also known as genitourinary syndrome of menopause, or GSM.
Yes, and they had been dealing with these severe symptoms for at least a year.
We really need to underline what GSM actually does to the cellular architecture, just so we can understand the magnitude of what the polynucleotides are trying to reverse here.
It's devastating for the tissue, isn't it?
It is. When estrogen levels plummet during menopause, the vaginal epithelium severely thins out. You lose the rugae, which are the natural stretchy folds of the tissue.
And the pH changes too, right?
Massively. The pH level changes, which makes the environment hostile and really prone to infection. The local blood flow decreases significantly, so it causes severe dryness, intense itching, micro tears, and debilitating pain that can utterly destroy a woman's quality of life.
And so many women go through this.
Nearly half of all postmenopausal women experience this. Yet the standard of care for decades has just been like temporary over-the-counter moisturizers. So this study was testing if PNs could actually reverse the biological clock of that specific tissue.
And to do that, the researchers utilized a very precise, highly synergetic 5-session protocol. They started with 3 what they called priming sessions.
Right, the foundation.
Yeah, and these used strictly polynucleotides using highly purified technology, or HPT, at a specific dose of 40 milligrams. Then, those 3 priming sessions were followed by 2 consolidation sessions.
This is where it gets really interesting.
It does, because here is the twist. For those last 2 sessions, they didn't use polynucleotides, they used hyaluronic acid. And all 5 of these sessions were spaced exactly 2 to 3 weeks apart.
The sequencing there is just a brilliant piece of biochemical strategy. Using the 40 milligrams of highly purified technology ensures you are getting an optimal concentration of DNA chains without any immunogenic proteins.
Which is why the salmon and trout sperm are used in the first place, by the way.
Exactly. The DNA structure is remarkably similar to human DNA, but stripping out the proteins prevents allergic reactions. So those 3 priming sessions of PNs act as the architects. They basically spend 6 weeks building a massive new cellular factory, upregulating the fibroblasts, and creating a dense new web of collagen and elastin.
And then, once the factory is built, you bring in the hyaluronic acid for the consolidation phase.
You got it. Hyaluronic acid is a glycosaminoglycan. It is essentially a complex sugar chain that binds to massive amounts of water.
So it's all about hydration at that point.
Right. You use the PNs to build the new extracellular matrix, and then you flood that new matrix with HA to provide the immediate water weight and the optimal aqueous environment for those newly active cells to thrive in.
Because you can't effectively hydrate a biological matrix that just doesn't exist.
Exactly. The PNs build the structure, and then the HA provides the ultimate hydration.
And the data by day 90 reflects just how powerful that synergy is. I mean, we are talking about staggering drops in symptom scores.
The numbers are incredible.
They really are. Itching dropped by 76.3%. Soreness and tingling dropped by 70.1%. Vaginal dryness improved by 59.1%. And dyspareunia, the pain during sex, dropped by almost 60%.
Keep in mind, these are patients who have been suffering for over a year.
Right, and seeing their tissue essentially rebuilt and rehydrated.
It is a profound functional restoration. The angiogenesis stimulated by the polynucleotides improves local blood flow, which naturally restores the healthy pH and mucosal secretions.
Yeah.
And then meanwhile, the HA is locking in that deep structural hydration.
Hold on, though, because I'm looking closely at the specific timeline in the study data, and I see a trend that, naturally invites a challenge.
Okay, let's hear it.
The data shows that most of these patients reported massive, meaningful symptom relief at the 30-day mark.
Which is immediately after just 2 sessions.
Exactly, after just 2 sessions of the polynucleotides. So, if I am the patient and I'm paying out of pocket for these treatments, if my severe dryness and itching are fundamentally resolved by week 4, you are going to have a very hard time convincing me to sit through and pay for 3 more sessions.
Yep.
Why not just stop right there?
It is literally the most common patient pushback clinics receive. And it fundamentally misunderstands the difference between an anti-inflammatory response and true neocollagenesis.
Oh, interesting. So it's not actually fully healed yet.
No, not at all. When the polynucleotides are first injected, one of their immediate secondary functions is massive free radical scavenging. They act as potent antioxidants, and they rapidly downregulate inflammatory cytokines in the tissue.
Okay, so the initial massive drop in symptoms isn't because the tissue is fully rebuilt. It's because you've aggressively put out the local chemical fire.
Exactly. The local inflammation is neutralized rapidly, and the PNs pull in enough initial moisture that you physically feel much, much better. But the actual structural repair, the creation and cross-linking of new, resilient collagen and elastin fibers that will make the vaginal wall strong enough to withstand friction without micro-tearing.
Right, the real heavy lifting.
Yeah, that metabolic process is still in its infancy at week 4. If you stop after 2 sessions simply because the surface level inflammation is gone, your underlying extracellular matrix is still weak.
So what happens when that initial effect wears off?
The moment that initial antioxidant effect wears off, the symptoms will return rapidly because the structural foundation hasn't been permanently strengthened.
Wow, okay. You essentially trick yourself into thinking the dam is rebuilt just because the floodwaters have temporarily receded.
That is exactly what happens.
So if you don't finish the 3 to 5 session protocol, you are shortchanging the biological minimum required to shift the tissue from a state of temporary anti-inflammatory relief to a state of sustained long-term regeneration.
Precisely. The consolidation phase is where the longevity of the treatment is actually secured.
Speaking of longevity, what happens after you finish that initial 5 session gauntlet? Say you at day 90. Your tissue is structurally rebuilt, hydrated, functionally younger. Does this state last forever? Are you just like discharged from the clinic for the rest of your life?
I mean, as transformative as regenerative medicine is, it hasn't completely conquered the forward march of time or, systemic hormonal decline.
Right, we're still aging.
The body continues to age.
Yeah.
And particularly for postmenopausal women, the systemic environment still lacks the circulating estrogen that naturally maintains this tissue on a daily basis.
Because menopause doesn't just go away.
Exactly. Because of that ongoing systemic deficit, the benefits of a full 5-session polynucleotide course typically last between 6 to 12 months.
Okay, so the timeline extends, but it eventually loops back around. What does the maintenance phase look like in the clinical protocols?
Well, to protect the investment of that newly built cellular architecture, clinics universally recommend a single maintenance session.
Just one.
Yeah, just a top-up. Depending on the patient's baseline health, this single top-up session occurs every 4 to 6 months. Some patients with incredibly resilient tissue might stretch that single maintenance session to every 9 months, but roughly twice a year is the clinical standard.
Just to keep the fibroblasts awake and active.
Exactly, keep the factory running.
Which highlights a crucial point from the sources, I think. While the 3 to 5 session rule is the clinical baseline, the exact number is highly customized to the individual's pathology.
It's very personalized.
Right. For instance, a younger patient in her late 30s who is using this strictly preventatively, or perhaps dealing with mild post-childbirth laxity, she might only need 3 initial sessions to reach optimal structural integrity.
That's very common for younger demographics.
But the patient dealing with severe long-term genitourinary syndrome of menopause is absolutely going to need the full 5 sessions.
Or potentially more. We also see extreme variations when treating specific dermatological conditions of the vulva, such as lichen sclerosis.
Oh, let's definitely touch on that, because the protocols for lichen sclerosis, or LS, are very intense. For those who aren't familiar, LS is a chronic inflammatory condition that causes severe itching, white plaques, and actual structural fusing of the intimate skin.
It's a really difficult condition to manage. Lichen sclerosis essentially traps the tissue in a devastating loop of chronic inflammation and scarring.
And how do PNs help with that?
Because polynucleotides uniquely modulate the local immune response and interrupt that specific inflammatory pathway, they are incredibly effective for LS. However,
Because it's autoimmune-like.
right, fighting against a chronic autoimmune-like condition requires maximum cellular signaling. An LS patient will unequivocally require the maximum initial sessions, often 5 or more, and a highly rigorous frequent maintenance schedule.
Just to constantly suppress the inflammation and prevent the tissue from reverting to a scarred state.
Exactly. It's a continuous battle for those patients.
And it's not just systemic diseases that alter your personal timeline. The sources make it super clear that your daily habits outside the clinic dictate how well the polynucleotides work inside the clinic.
Absolutely. We have to remember that polynucleotides are simply a signaling mechanism. Like you said earlier, they are handing over the blueprints and asking your body to do the physical work.
But if the workers are sick,
Right. If your systemic biological environment is compromised, the local work will be severely hindered.
I was actually reading about the impact of smoking on this specific treatment. Because smoking acts as a severe vasoconstrictor, it restricts the microscopic blood vessels.
It's terrible for tissue healing.
So if you are smoking, you are literally choking off the oxygen supply to the exact tissue you are trying to heal.
And not just oxygen, but the delivery of vital nutrients too. A poor diet lacking in vitamin C or essential amino acids directly deprives your newly awakened fibroblasts of the raw metabolic materials they need to synthesize collagen.
So you're giving them the blueprints, but no bricks.
Exactly. The polynucleotides can scream at the fibroblast to build collagen all day long, but if the patient's systemic environment doesn't provide the cellular building blocks, the structural repair will just fail.
So if you are a heavy smoker or you are chronically dehydrated and highly stressed, your body is effectively ignoring the biochemical instructions the polynucleotides are giving.
Pretty much.
You might end up needing 6 or 7 initial sessions and maintenance top-ups every 3 months just to fight against the current of your own lifestyle choices.
Your cellular efficiency is fundamentally dictated by your systemic health. The healthier your internal environment, the more responsive those A2A receptors will be, and the longer lasting your regenerative results will be. It is a deeply interconnected biological system.
It's the ultimate reality check for aesthetic and regenerative medicine, really. You cannot hand the architectural blueprints to a starved, suffocated construction crew and expect a masterpiece.
No, you certainly cannot.
So for you listening, let's distill all of this clinical data into the absolute core takeaways. If you are exploring the world of intimate polynucleotides, whether it's to combat severe menopausal atrophy, recover from postpartum trauma, or manage a chronic condition like lichen sclerosis, you must prepare for a biological timeline, not an instant fix.
The clinical baseline is a foundational course of 3 to 5 sessions.
And you must adhere strictly to the 2 to 3 week spacing between those sessions. That optimizes the mitotic cycle of your cells without causing that receptor burnout you mentioned.
Echophylaxis, yes.
Right. And once you have built that new healthy extracellular matrix, you protect that biological investment with a single maintenance session roughly every 6 months, customized to your specific lifestyle and systemic health.
It undeniably requires patience and a real commitment to the process. But as the Palmier study so clearly quantified, the profound functional restoration and the return of quality of life make that timeline entirely worthwhile.
It is a phenomenal shift in medical science. And before we close out this deep dive, I want to leave you with a broader thought to consider. For decades, the standard of care for women suffering from intimate tissue degradation has been incredibly limited.
Severely limited.
We've relied on masking symptoms with messy, temporary over-the-counter creams, or we've relied entirely on systemic hormone replacement therapy, which carries its own complex risk profiles and, frankly, simply isn't safe or suitable for every patient.
And that is the true paradigm shift we are witnessing right now. We are moving away from temporary symptom management, and we're moving away from systemic hormonal manipulation toward locally rewriting the biological health of the tissues at a cellular DNA level.
It's revolutionary.
It really forces a fascinating question about the future of women's health. As these highly purified DNA treatments become more refined and accessible, could regenerative medicine eventually become the absolute first-line standard of care?
Wow. Yeah.
Could we see a near future where local cellular reprogramming entirely replaces the temporary creams and systemic treatments we rely on today for menopausal and postpartum recovery?
It's an incredibly powerful thought. Imagine a medical landscape where we don't just treat the pain of aging tissue, but we actually command the body to rebuild the functional architecture like it was decades younger. Thank you so much for joining us on this deep dive. Keep questioning the consensus, keep exploring the fascinating mechanisms of regenerative health, and remember, the most profound biological changes are always worth the wait.